Hello, and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and chapter immunization representative at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of October 25th, a momentous week in terms of looking at pediatric vaccine indication for kids ages 5 through 11. More about that in just a little bit. First, the tally of where we're at with total number of cases. Unfortunately, there's been a significant increase both globally as well as in the United States since I last recorded this podcast. Globally, we were up to 244,375,000 plus total cases, with 4.96 million deaths recorded since the start of the pandemic. In the United States alone, we have almost 6 million total cases and over 738,000 deaths since the start of the pandemic. In kids, again, this data coming to us from the AAP as of October 21st, we are up to almost 6.3 million total cases since the start of the pandemic, which is 16.5% total of the total number of cases on average. And it comes out to a number of 8,300, actually almost 8,400 per 100,000 patients of pediatric age range. Last week alone, kids accounted for 25.1% of the total number of new cases. And this has been an ongoing trend, anywhere from 25 to almost 30% of the new cases have been pediatrics, again, 0 through at least age 18, 0 through age 19. In Arizona, we're up to 216,036 total cases, which is 19% of the total cumulative cases from the start of the pandemic. Comes out to 11,750 pediatric cases per 100,000 patients of pediatric age range. We are up to, very unfortunately, 40 deaths related to COVID-19 in pediatric patients since the start. We remain second to Texas, which has 99 deaths, and just a little bit higher than California with 37 deaths. So again, the pandemic has been significant and increasingly significant for pediatric cases. Thankfully, overall, the severity has not been extreme. However, we continue to encounter individual cases, many of whom are children with special needs, who have a very, very difficult course with COVID-19. We also are continuing to encounter severe cases of MISC, the multi-system inflammatory syndrome in children, which is, so far as we can tell, not preventable and an unfortunate reality of our pediatric patients, even those who have mild or even asymptomatic disease. So we have just a couple questions to talk about for the podcast this week. The first is, what is the current recommendation regarding timing between COVID shots and flu shots and or even other recommended vaccines? Fortunately, the initial recommendations to wait a minimum of 2 weeks before or after COVID-19 vaccines has been revised down to no wait at all. So in fact, both from a wish to increase vaccine coverage rates, but also due to the science of looking at seroprotective levels, there is no deficit, there's no need to delay vaccines before or after the COVID-19 vaccine, and specifically for COVID vaccination and influenza vaccination. So for those patients of ours who are able to get an emergency use authorized vaccine against COVID-19, it is very reasonable, in fact, a wise idea, if possible, to give them both the COVID vaccine and their influenza vaccine at the same clinic visit. That said, there may be some patients who are reluctant to have both of their deltoids sore for the next several days and may wish to delay for a certain period of time. It is quite reasonable to delay 1 day, 2 days, 3 days, 2 weeks, etc. So there really is no need, or actually no specific recommendations to wait any period of time before or after the COVID-19 vaccine. And similarly with other routine vaccines, of course, we continue to experience delays in routine vaccinations due to many issues regarding related to the pandemic. So for those patients who thankfully are coming into a clinic visit and potentially can participate in catch-up immunizations, go for it. Absolutely. Try and get them all vaccinated as quickly as possible. The next question is related, and this is, are there any research studies looking at combining influenza and COVID-19 vaccines? And yes, there are. Many of them, that would suggest there are a lot. There are a few studies looking at the combination products, and those studies are by and large occurring in other parts of the world. And so far, they have shown very good efficacy. The challenge is that the COVID vaccine product that is being tested in combination with a relatively regular or a routine flu vaccine product is not one of the ones that has been safety tested here in the States. So it would be hard to translate that data and those results to a product in the United States in any degree of foreseeable future. However, at least the research would suggest that combining the two continues to provide adequate to good seroprotective levels against both SARS coronavirus 2 and influenza A and B of the serotypes that are currently being anticipated around the world. And then the third question, again, related, is there or are there research studies examining flu vaccines made as a mRNA vaccine? And once again, yes. In fact, the research behind mRNA vaccines is well over a decade old. And in fact, the science behind it, the exploration of the science, was hitting the scientific airways, if you will, that 25 years ago. So once again, for those of our parents or potentially patients who have concerns about this being a new vaccine technology, that is not true. mRNA vaccine technology has been around for quite some time. And there are vaccine products that have been examined and tested, both in the laboratory setting as well as in primate studies for other types of infections, now including influenza. So my suspicion is, and this is just my suspicion, that as we go further into the pandemic, hopefully as we transition from pandemic to endemic status, and the concept of mRNA vaccines continues to gain acceptance, that we will see more and more products, vaccine products of all types of protection against infection, which are mRNA based. Certainly the concept, the science, the safety studies have been largely excellent, and the outcomes, again, have been superior to those which have been obtained by the adenovirus vectored vaccines and other vaccine products. So, boy, it would be fantastic if we could get a successful influenza vaccine based on an mRNA platform that would have more than the typically expected 40 to maybe even less % protective efficacy in a typical epidemic year. So fingers crossed. Science is being worked on as we speak. I think certainly nothing to turn into a formal product yet, but I think we can anticipate evolution of vaccine status into the mRNA way in the next year, quite honestly. So that's it for the questions. However, of course, the big news, as anybody who is listening to this is likely aware, is the ongoing approval process for the Pfizer mRNA vaccine indication for children ages 5 through 11 years of age. And as I record this podcast on Tuesday, October 26th, the FDA subcommittee has just given its approval for authorization of use for the Pfizer vaccine in that age group. We next anticipate a decision, both assessment by and then decision from the CDC and its task force on November 2nd to 3rd. And of course, a whole bunch of eager ears are anticipating a very positive discussion. At this stage, I think, hoping I'm not jinxing the process, but I think it would be unlikely for Dr. Rochelle Walensky, who is the director of the CDC, to go counter to the advice of the FDA. I mean, certainly such decisions have occurred, but typically with very good reason. But the science behind this specific vaccine and its both safety and efficacy for ages 5 through 11 is solid. 90 to 91% protective efficacy against all infection. Once again, high 90s, 98, 99, even 100% protective efficacy against severe disease, ICU transfer, and hospitalization in children ages 5 through 11. Keep in mind that this is a vaccine dosage which is different than that of the adult formulation and young adult / older adolescent formulation. The pediatric age 5 through 11 formulation is a third of the dose, which is administered in the other Pfizer vaccine product. Potentially, I think related to that then, the reported incidence and severity of side effects has been low and mild, respectively. So indeed, of course, as you would expect, kids in the study did report sore arms lasting, honestly, no longer than the day or two that many of us experienced with our COVID vaccines. And the incidence of malaise, fevers, nausea, headaches, any of the other fairly routine reactions that others have reported with the COVID vaccine, those have been very mild in nature, very few even moderate reports, and no severe reports of any side effects. Importantly, as I'm sure we're all eagerly awaiting, there has been no increased safety signal, meaning a concern from safety perspective, for post-Pfizer vaccine myocarditis in this age group. Yes, of course, I think we're all quite aware there is an association with both the Moderna and the Pfizer mRNA vaccine products in adolescents, young adults, with a mild post-vaccine myocarditis. I've managed several now. All of them have been quite responsive to simple use of nonsteroidal anti-inflammatory drug, especially ibuprofen. And none have had any lasting or severe impact on their myocardial function, their cardiac status, etc. Those few patients, relatively speaking, who have been hospitalized have had a short hospital stay, and their post-discharge follow-up by echocardiogram or cardiac MRI has uniformly been excellent. So, okay, great. We know that there is an association with the mRNA COVID vaccine and post-vaccination myocarditis in adolescents and young adults. But so far, that signal or that concern has not yet been described with the Pfizer third of a dose vaccine in the younger age kids. To be fair, the concern for myocarditis post-vaccine did not begin to emerge until after emergency use authorization had already been considered and vaccine was being delivered to that age group in other parts of the world. So we may yet still see an emergence of that safety signal, but at least for right now, going into the approval process for emergency use authorization, that concern is not evident. So the vaccine itself appears to be safe. It appears to be highly efficacious, highly successful. And of course, this is a remaining at-risk patient population that we desperately need to immunize. Now, of course, I think we need to realize, again, the pediatric COVID-19 is typically not a severe disease, except when it is, and except when it's associated with MIS-C. But what we're also trying to counter is the now emerging risk that children of that age group, 5 through 11, and even 11 through 17, are now known to be increasingly super carriers of SARS coronavirus 2. This is a new finding. This is a game changer with our lovely gift of the Delta variant, in that it is more contagious in general, likely because it creates or binds more readily to its targets on respiratory epithelium, and thus precipitates a higher viral load. So it is now evident, based on population studies, that pediatric patients 5 and up, and even younger, actually 6 months and up, are now carrying a higher viral load when infected with the Delta variant of SARS coronavirus 2 and are likely to be more contagious. And in fact, there are studies now showing increased transmission of virus from that pediatric patient population to other family members, to adult caretakers, to contacts at school, etc. So even if we're not as concerned about preventing a severe COVID-19 hospitalization or death in a pediatric patient, yet we still need to be concerned about addressing the pandemic. And while we still have a very robust possible transmitter population in the United States and worldwide, we will not get over this pandemic. So, again, as arguing, or I should say, talking points perhaps to use with our families, our patients, our staff, a major thrust of pediatric COVID vaccine, in addition to patient safety and protection, also needs to be societal health and an ability to hopefully might finally get past pandemic status and resolve into endemic or perhaps maybe even epidemic status. So fingers are crossed that is what happens. For the rest of us, of course, we're also looking at or waiting for data from Moderna vaccine. And in fact, Moderna has now released from its advisory committee word that it is completing its studies in ages 6 through 12 and then 6 even through 17. And that vaccine, Moderna vaccine, is just as efficacious and safe as it has been in other patient populations. No word yet on when Moderna will go to the FDA for the younger age patient indication or emergency use authorization. But at the very least, we're a step closer in that data is now being discussed publicly and it is to be hoped, will be released in peer review form so that we can see that data as well. Similarly, Johnson & Johnson, the Janssen Pharmaceuticals vaccine, which in other news is now being suggested as a booster dose, which you might call a second dose for those who received the first one in the older patients. They also are continuing to study the younger age population, but no word yet on how safe or how effective that vaccine is in the younger populations, or even when that data shall be released. So a whole bunch going on in terms of pediatric vaccine indications. Obviously, and I'm sure that the rest of us are eagerly awaiting the formal approval so that we can begin to vaccinate the younger kids with the Pfizer vaccine. A word to that, doses are already being pre-ordered and will be pre-positioned in place, perhaps hopefully in many of your offices, and ready to be administered. Please do not administer them to kids younger than age 12 until the formal approval goes through. Again, just it would create a world of headaches and noise, and we don't want to jeopardize in any way the mission of vaccinating younger kids with any oopses. However, as soon as that official word comes through from Dr. Walensky and the CDC, I'm hoping even November 2nd. That would be fantastic. But November 2nd or 3rd is the decision window. As soon as it's approved, and if you have the pediatric formulation of the Pfizer vaccine in your office, go for it, start, fantastic. And for those of us who are not yet online to get vaccine delivery, I encourage us to do so. I think now is the time to capture or recapture our pediatric offices, our primary care offices, as the medical home they need to be to address the vaccine needs for our patients, and not just with COVID, but to set the stage to bring other routine vaccines up to speed. So now is the time to be seen as the source of the pediatric COVID vaccine, and hopefully not have to send our kids to the pharmacists and the pharmacies, which again are a decent option, of course, without going too deeply into the politics of things. But I would far prefer, as I imagine all of us do as well, that we bring the kids to our offices. Let's take care of them, provide the preventative health care that we would otherwise like to communicate, and recapture regular routine pediatric healthcare visits. So that's what I have to share with you for this week. As always, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. AzAAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. And as an aside, the chapter is also partnering with National AAP and the CDC in a funded project to engage our school systems as a source of additional information and increased vaccine uptake for the COVID vaccine. We have a robust team created that has just finished its 9 hours of orientation. And I think you can anticipate more on this podcast and hopefully interviews as well of our team members giving status updates as we engage our students and their families through the school systems to increase COVID vaccine awareness and uptake. So, in the meantime, for more information and for resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. Hang in there as always, folks. Thank you all so much for your service. Be well.